Hello everybody, this video is going to talk about type 1 diabetes mellitus, and I'm going to try to explain to you guys some of the basic pathophysiology behind this disease and also some of the treatments that are currently available. So let's begin. What is type 1 diabetes mellitus? Well, type 1 diabetes mellitus is an autoimmune disease that is characterized by pancreatic beta cell destruction, leading to insulin deficiency. Now keep in mind that at least 90% of the pancreatic beta cells must be destroyed before symptoms can be seen. Type 1 diabetes mellitus also begins early in life. Now this is a direct contrast to type 2 diabetes mellitus, which takes years and years to develop. So now we've defined type 1 diabetes mellitus, and you're probably wondering, what does somebody with type 1 diabetes mellitus look like? Well, typically, they will present with polyuria, or excessive urination, polydipsia, or excessive thirst, and polyphagia, excessive hunger. They will also present with weight loss, and this is because the body is forced to break down fat as an energy source. As you guys probably know, the body uses two main sources of energy. One is glucose, and one is fat. In somebody with type 1 diabetes mellitus, their body is simply unable to use glucose as an energy source, and therefore, the body is forced to break down fatty acids. This brings us to our next point. Ketoacidosis is one of the most important complications of type 1 diabetes mellitus. What actually happens is, as the body of an uncontrolled type 1 diabetic patient undergoes fatty acid oxidation, ketone bodies begin to rise in the bloodstream. This is dangerous because ketone bodies are acidic, which means that in large amounts, they will actually lower the pH of the blood and could potentially cause severe metabolic acidosis. Now we're going to move on to treatment. How do we treat type 1 diabetic patients? Well, as mentioned earlier, type 1 diabetes is characterized by beta cell destruction, which means that these patients have very low insulin levels or virtually no insulin levels. So obviously what we're going to do is give them insulin, and that's exactly what we do. There are four types of insulin. Regular, these are the endogenous insulin that are found in humans. There are rapid-acting analogs such as Lispro and Aspart. There are intermediate-acting analogs such as neutroprotamine Hagedorn. And there are long-acting analogs such as Detamir and Glargine. What happens is the doctor will provide a combination of different analogs that will cater to the patient's need. The standard therapy provided today is the use of NPH and regular insulin. Let me ask you guys a question. Is it possible to give patients insulin or insulin analogs orally? I'll give you guys a second to think. I hope you said no. The reason is because insulin and all insulin analogs are proteins, and as you probably learned in your GI physiology class, proteins are rapidly broken down in our stomach and in our duodenum. So if you give somebody insulin orally, it's just going to be broken down and the drug will be useless. Let's move on now to the side effects of insulin therapy. The most obvious side effect is hypoglycemia. Now this is something you have to keep in mind because low levels of blood glucose can cause palpitations, sweating, and nausea. And if serious enough, it could cause convulsions and seizures and even coma and death. And just like every other drug in the world, there are some people who are allergic to insulin, although this is extremely rare. Well, this slide basically just summarizes some of the insulin analogs that we were talking about earlier. This is not terribly important, although I know some of you guys might have to memorize this for your exams. So what I've done is I've taken some mnemonics off the web, which I found useful. So have a look at them, and I hope it helps you out. And finally, we're going to talk about amylin. Amylin is a substance that's made by beta cells in the pancreas, and they're also secreted along with insulin. Amylin analogs, such as pramlintide, are able to decrease the risk of hypoglycemia by reducing the dose of rapid-acting insulin by as much as 50%. Now do keep in mind though that amylin analogs are not a substitute for insulin. They are given in addition to insulin therapy and not to be given alone. Well, This concludes our video on type 1 diabetes mellitus. I hope you found it useful. If you did, please don't forget to subscribe to our channel. In our next video, we'll be talking about type 2 diabetes mellitus, and we'll also be outlining some of the differences between type 1 and type 2.